everyone, and welcome. Thank you for listening to the Voice of Pancreatic Cancer podcast. If it's your first time joining us, we are a pancreatic cancer nonprofit that is committed to the awareness, prevention, and cure of pancreatic cancer. I'm joined today, hosting with me, Dr. Susan Tsai from the Medical College of Wisconsin. She is a regular here on the podcast and always asks the best questions. So I'm also excited to introduce our guest, Dr. Alexandria Fawn. Dr. Fawn received her medical doctorate from the University of California at Irvine. She trained in internal medicine at Baylor College of Medicine, and she completed her hematology oncology fellowship at the University of Texas MD Anderson Cancer Center. Welcome, Dr. Fawn. Thank you so much for joining us.
Thank you so much for having me here today.
Well, we're really excited, especially because one of your focuses is neuroendocrine tumors. And so that's what we're going to be talking about today.
20 years ago, not a lot of people were interested in neuroendocrine tumor. And there's not a lot of treatment for neuroendocrine tumor, pancreatic neuroendocrine tumor in general. So I got interested in it because it's in my nature to find disease that is lacking treatment and lacking expertise. So I started MD Anderson, University of Texas and MD Anderson as a faculty. And I had this as one of my focus. And initially, I thought it was just a pastime focus, just to develop something, see patient, make sure they are taken care of well. But over the years, it becomes, this is all I see. So as a result of that, that's how I became an expert. But I also don't think of myself just an expert. I think I'm also an advocate for patients with pancreatic neuroendocrine tumor.
And Alex, it's such an interesting tumor biology. I mean, I think on this podcast, we talk about pancreas cancer a lot, and it's honestly so different from pancreatic adenocarcinoma. So maybe for folks who are new to neuroendocrine tumors, maybe could you just tell us how you kind of explain this tumor to your patients when they're first diagnosed?
The majority of pancreatic cancer are adenocarcinoma. Then there's less, meaning in the 85 to 90% are adenocarcinoma. The rest are the rare disease. And these rare diseases are neuroendocrine tumor of the pancreas because they derive from the endocrine cells of the pancreas rather than the ductal cells of the pancreas.
And I find it so interesting too, because the biology, I think when people hear that they have a pancreatic neuroendocrine tumor, and sometimes when I see them, they're a little bit frantic because they think it's an adenocarcinoma, but the biology seems quite different. Can you speak to that a little bit as well, like the timeline?
Yeah, so I think you are totally right. Patients are equating adenocarcinoma with pancreatic neuroendocrine tumor. They all lumped it to be pancreatic cancer, but they shouldn't be because they're very, very different. The very fact that it's rare, but it's also biology in the sense that the disease is lower growing and it typically has other symptoms associated with it, meaning sometimes these pancreatic neuroendocrine tumor can produce hormones. And so they have symptoms relating to hormone being oversecreted. And I think the media doesn't help when they lump all patients with cancer of the pancreas to be one. For example, we all know Aretha Franklin has pancreatic neuroendocrine tumor, not pancreatic cancer. So patients still come to see me and talk about these kind of things. They mix between those two. So it's very important to tell the patient this is a very different cancer from pancreatic adenocarcinoma. The cancer course is typically more indolent. The prognosis is typically is better. And majority of the patient have no symptoms except from the typical cancer being enlarging or mass of the cancer enlarging. But a small portion also have a hormonal secretion symptoms like insulinoma, glucagonoma, and so on. Yes. So it's very important to differentiate that with the patients. And oftentimes patients would leave the office after hearing that this is an indolent disease. It's a very different from adenocarcinoma, and the approach is also very different from adenocarcinoma as far as treatment. And the life expectancy and prognosis, they leave feeling a little bit better than this frantic, it's all over. So I think that's important to make that distinction initially. And it's also important to make that distinction with biopsy. So every single time you see a pancreatic mass with liver metastasis, you don't assume always that it's adenocarcinoma, because there's a possibility of other different rare cancer of the pancreas.
Can you talk a little bit about how one is, I guess you would say, less severe?
All cancer ultimately do go through those stages, and they can progress from localized to metastasize, and metastasize is oftentimes incurable. But because pancreatic neuroendocrine tumor is less aggressive, and patients typically are healthier, meaning they don't have as much of the severe symptoms of cachexia and constitutional symptoms such as weight loss and so on. These patients, we can use other modality like surgery, even in the setting of metastatic disease for these patients. So it's important to distinguish that. And then because it's slower growing, that doesn't mean that it doesn't grow and progress. It's just slower growing. It allows us more time to start treating them with treatment that's not the traditional chemotherapy that patients fear.
Thank you so much. That was a great summary. I wonder if you could maybe walk us through your diagnostic process for a new patient who's diagnosed with neuroendocrine tumor. You mentioned some hormones. So maybe could you explain, do you check hormones on everyone? Do you biopsy everyone? Are there any more diagnostic imaging studies that you think are important for a new person who's just coming into your office with a new diagnosis?
Yes, thank you. That's actually important. And this is where the distinction between, some place that does this all the time and some place that doesn't do it all the time. And that's why it's important patient sees us. So for me, for a patient who comes in with a diagnosis of neuroendocrine tumor, they're usually got that diagnosed either from a biopsy at the pancreas or the biopsy of a liver metastasis that are seen. After the diagnosis is made, I actually assess the patient and see if there's any hormonal syndrome or clinical symptoms that I can assess. Let's say their sugar has been waxes and waning, they have long-standing dyspepsia or get ulcers that is in a peculiar location of the stomach or duodenum. Then I use my clinical assessment to then check for hormonal value. The blood level of hormones, insulin, glucagon. Insulin and glucagonoma are not very common, so we don't necessarily do insulin and glucagon immediately. So the hormonal workup for me is based on clinical assessment. But the standard that I do at baseline that I use is chromogranate A, and as a way of measurement. And chromogranate A is a marker that is oftentimes misunderstood. It's not always correlative to hormonal secretion. It actually can be used as a prognostic marker of your disease process as well. And so I use that as another marker I use to start the patient with. If it's normal at the beginning, I don't continue measuring them. That's it. But it's abnormal. That's usually for me a poor prognosis. And so I do use them to follow their course of disease. As far as other workup that I need to do, we call that staging. The initial staging is done with imaging, trying to look to see if other sites of disease are involved. And we're looking to assess extent of disease. So that's done with CT or MRI, which most of the patient will come already. Here's the caveat. Most patients will have a pancreatic mass, but they don't have any distant disease based on CT. But the CT from the outside sometimes may not be multiphasic to look in the liver. For pancreatic neuroendocrine tumor, they're very vascular disease, so we need to do a specific liver assessment of their disease with an MRI for multiphasic to look to make sure there's no liver metastasis. Sometimes there's occult metastasis into the liver. The last scan that I usually do is a PET dotatate. That could be a gallium-68 or copper-64. That will help looking for two things. It looks for extent of disease, but it also looks for somatostatin receptor on these tumor. If there is somatostatin receptor, that's also an option for therapeutic intervention in the future. So CT, MRI, and PET dotatate are the baseline imaging, and hormonal marker. Baseline for me is chromogranin A, and then other hormones based on clinical findings.
That's awesome. I've always wanted to be like a fly in the wall in your clinic. So this has been very helpful.
You're very kind. My clinics can be very interesting.
Especially, I think we talk about this on the other side, on the adenocarcinoma side too, but not all CT scans are created equally. And so the multiphasic or dual phase scan that you are talking about is so important, not only for adeno, but for neuroendocrine tumor. And I think the dotatate has been like really amazing, a little bit transformative, I would say, in the last 5 years, 6 years.
Probably. It was approved in 2014 or 16. Yeah.
Okay.
Yeah. So
10
it's
years, almost.
yeah.
That's
And I can tell you, it's very interesting. When I first started this field, we used to do octreotide scan. It's such a blurry vision. And then we're so excited when octreotide scan, which is a nuclear scan, can be fused with a CT imaging, but it's still so fuzzy. And now nobody order octreotide scan anymore. So the field has transformed. Yes.
So you mentioned at the beginning, like how it's important when people are first getting diagnosed to go to someone that sees this a lot. I was just wondering if you could expand on that a little bit.
The incidence of neuroendocrine tumor is increasing, and patients are living longer. So the prevalence of neuroendocrine tumor is also increasing over the years. So you see patients being taken care of with neuroendocrine tumor by general oncologists or somebody in the community. But it's important even initially or intermittently that they see a specialist in neuroendocrine tumor. And I'm not talking about a single specialist. I'm talking about a center that has counterpart with surgery, radiation oncology, interventional oncology, and as well as nuclear medicine that treat for this disease. And the reason is this: the expertise is in the ability for us to discuss the patient and to gauge the best personalized treatment for the patient, the one that is tailor-made for the patient. But the expertise comes in is very useful because, for example, for me, and I can only talk about myself, is that I can see where they're going based on how they're responding and what likely treatment I'm going to line them up. Because I think oftentimes when you see a general oncologist, they react to, progress, do this, because that there's guideline. But I actually will say, let's not do this, because if you do this, you may block the treatment next to the next treatment or the next treatment, and the complication that comes about long term, because I see the patient full spectrum. And then the other thing is, in the center that is multidisciplinary, oftentimes has research that's going on. And research is, you hear the word research and different people have different reaction to it, but research is a novel treatment option that the patient may not have if they're not enrolled onto clinical trial, and assessing if they need that at that point in time, or this clinical research is better for them than just standard of care, is the role of a center of expertise or an expert in neuroendocrine tumor.
For people who take care of neuroendocrine tumor patients like yourself, I mean, it's really a long game. Like, it's not like a 5-year survival, it's like 10 or more year survival. So it's really important that there's a really thoughtful approach. So it's great to hear that. I wonder if you could talk about a little bit, with neuroendocrine tumors, we talk a lot about the staging, I guess, which is what we do for adeno too. But specifically, we always talk about grade or proliferative index too for neuroendocrine tumors. And maybe for people listening who may be not familiar with kind of that aspect, could you talk about how assessing that, like, do you do that on every patient that comes through the door? Let's say they just have a localized tumor. Do you biopsy always just to see what the proliferative index is? How do you approach that, and how does that affect treatment?
Thank you, Susan. I see why Miranda said you asked such great question. These are very important questions. So thank you for asking the question, because so there are 3 things. It used to be 3, but fundamentally there are 3 things or 3 factors that makes up the prognosis of of a patient with neuroendocrine tumor. the stage of disease, that means the extent of disease, the type of disease, is it well differentiated or poorly differentiated, because that dictate whether they progress or they grow fast or grow slow. And then the last one is the location of the tumor, where it's from, whether it's from the pancreas or it's from the small bowel. Going back to the grade of tumor or the type of neuroendocrine tumor, well-differentiated neuroendocrine tumor behave more indolently, meaning if there's such an adjective, they grow slower. And the Ki-67 is a stain that we use on the tumors, immunohistochemical stain that we use to look for the proliferative, how fast the tumor grow. It's based on percent of a certain stain. The stain indicate the proliferative index of the tumor. So that is the reason why we do this for every single patient. If it's a poorly differentiated neuroendocrine tumor of the pancreas, they typically will progress very quickly, and they do indicate that they may likely need systemic traditional chemotherapy at some point in their course of disease. So yes, Ki-67, a proliferative index, and the differentiation of your tumor or grade of tumor is part of a prognostic foundation, but it also helps us dictate how the natural history of disease and what treatment we typically should give for these patients.
Great, that's super helpful. And just as a side note, because I'm curious on this as well, in pancreatic adeno, we're doing a lot of molecular profiling, like we send the tumors out for all sorts of genetic testing or transcriptomic testing. Are you doing that for neuroendocrine tumors? Or do you think that's a little bit too premature?
No, I think this is something that we need to do because, so my philosophy behind that is it's always better to know and to treat based on data than not knowing. So even though it's not necessarily recommended on the NCCN guideline, in my practice, all patient comes in with tumor, especially for metastatic pancreatic neuroendocrine tumor, get their tumor profile with next-gen sequencing. So I know what treatment they're likely will have, and then I can use that to determine, should they start with a clinical trial, should they start with a targeted therapy, or should they start with standard frontline therapy on the NCCN guideline? That is helpful for me. But using the next-gen sequencing of their tumor, meaning the profiling of their tumor, will help me also prognosticate it, their tumor. There are certain genes that actually predict that this is a poor behaving pancreatic neuroendocrine tumor versus the other one. So I do use them for many reasons, and all patient in my clinic gets that. As to germline testing, meaning looking to see if they have hereditary condition that is linked to this, I use my family history to help me guide that and not just do for everybody. If somebody who's very young coming in with multiple pancreatic neuroendocrine tumor, definitely they buy themselves a germline testing, which is the testing to see if they have inherit a gene versus tumor profiling. Yeah, no, I do that for all my patients. So I think that even though it's a little early and the guideline is not changed, but I think it's the way of the future. And for me, my reason is that I'd rather have data so I can make the most informed decision for my patient or guide them in that decision.
Yeah. I definitely want to follow you in your clinic. This has been so informative for me. So Alex, can you tell us how you approach the decision-making for treatment for patients with metastatic neuroendocrine tumor?
The decision on picking one treatment over the other for a patient with metastatic pancreatic neuroendocrine tumor is based on many factors, but the factors that is important is the patient factors, where they are in comorbidity, the disease state, meaning is it a bulky disease or not bulky disease, and is it functional, meaning produce hormone or not, and then the goal of treatment. Is it that the patient is going for surgery, meaning if they have a chance for curative debulking or curative resection of the primary, whatever it is, goal of treatment is important. Patient characteristic is important. And then, of course, the bulkiness of the cancer. How is the cancer characteristic? Functional, bulkiness, whatever. Those are the three criteria I use to help navigate my treatment decision for patients.
Dr. Fun, thank you so much for your time. All of this was just very important what we talked about today. I know that a lot of our patients are going to be really excited to learn about the things that we talked about. We have decided that we will have an episode 2 because we still have a lot of questions for you, Dr. Fahn. So please make some more time for us. But we just want to thank you and looking forward to continuing this conversation.
It's been fabulous. Thank you for having me. Thank you, Susan, and thank you, Miranda.
Thank you, guys.